Well, I just want to welcome you again to today's webinar. My name is October E. Boyles. I am the Chief Clinical Officer for ICANotes, and my background is I'm a registered nurse. I'm coming up on my 19th year of being an RN, and that scares me when I say it out loud. But before we begin, I have to tell you that I like to ask questions during my webinar. I don't like people to feel that someone's talking to them and not engaging. So throughout the webinar, I'm going to be asking you questions, and I would love for you to participate if you feel comfortable. And I want you to ask questions to me as well. But again, thank you so much for joining. We're going to be reviewing tips for writing better mental health SOAP notes in the present day. And the SOAP note is an acronym for Subjective, Objective, Assessment, and Plan. And a lot of you have probably memorized that and can say that in your sleep. It's the most common, the SOAP note is the most common and universal form of documentation used by mental health clinicians in patients' and clients' medical records. And SOAP notes allow providers and clinicians to document, to receive, and distribute information in a comprehensive, efficient, and simple to read configuration. Now, before we jump into how to write a SOAP note, I'm going to spend a few minutes talking about the history of a SOAP note and how that really began. So the history of the SOAP note, it came from a method of documentation called problem-oriented medical record. But there were some limitations on the POMR, the problem-oriented medical record system. And some of those limitations that caused the POMR to be underutilized included the perception of providers that the system was too complex overall to maintain once the entries had begun, and some providers felt overwhelmed by data overload as a result. And that is somewhat in part because there was often a need to link across entry boundaries, which resulted in additional work. And that's the last thing we all want, is additional work, right? So some people still use the POMR, the problem-oriented medical record, but not the majority. Now, have you heard of the PMOR? How many of you have heard of it? If you haven't, type no into the chat. If you have, just type yes into the chat. If you're using it, type yes into the chat. I just want to get a kind of a nice consensus of folks that have. So I'm getting a lot of no's. Nope. Yes. All right. I like it. Yeah. So again, it started out to be really good, and it didn't quite take off. But the one man that started it, he's the one that created the problem-oriented medical record. And you may have heard of this man. We call him the father of the SOAP note. And so this is Dr. Lawrence Reed, and unfortunately he passed away 2 years ago, but he is responsible for introducing a system for organizing patient data, and this was back in the 1950s, and it's still used in hospitals all over the world. And he led the way in developing a computerized method for aiding in diagnosis and treatment of disease. Now, two of the components of the POMR, the problem-oriented medical record, have become practically universal in healthcare. And the first one is the compiling of a problem list. And I'm sure if you use an EHR, you have seen a problem list, or even on paper, their problem list documented. The second that came out of the POMR is a SOAP note. So it's a SOAP note system. And so if you've heard of Dr. Reed before, it's probably because it's not necessarily related to his SOAP note context, but it's by his book. So Dr. Reed and his son wrote a 280-page book called Medicine in Denial, a bit controversial. And that book was based on what he felt were the deep disorders that pervade medical practice. And he felt that these disorders were distinguished in euphemisms that we call, and you're probably familiar with, clinical judgment, evidence-based medicine. He felt that those disorders exist because medical practice lacks a true system of care. And he felt the missing system had two core elements: standards of care for managing clinical information and electronic information tools designed to implement those standards. Now, when he wrote that book, he was actually correct. However, the advances in technology over the past several years, I believe he would be impressed. Now, just out of curiosity, how many of you have heard of Dr. Reed? How many of you have heard, just out of curiosity? Helen, I love your statement. No, when I'm old, you're hilarious. So no, a lot of you haven't. Okay. All right. It's a good book. It's a good read. It's not relevant really now when he wrote the book, but just because of our advances in technology. But he was on the right path. And so I think, again, if he was alive, he would be really happy with the things that came to fruition. So enough about Dr. Weed, even though he's a wonderful man and he provided us with what we're going to be going over today, but let's just jump right into the SOAP format. So the SOAP format, as you know, again, is subjective, objective, assessment, and plan. And it's the ideal standard to follow for providing necessary information. But really, we wonder if people are taking full advantage of this format. And one of the main questions I get is, who uses the SOAP format? Well, just about everyone, from prescribers to counselors, nurses, occupational therapy, recreational therapy, physical therapy, even dietitians. They use a SOAP note format. And the reason it's so popular is because a SOAP note helps guide healthcare workers to use clinical reasoning to assess, diagnose, and care for the patient or client based on the information provided by them. So SOAP notes are a pretty essential portion of information about the health status of a patient, as well as serving as that communication document between healthcare professionals. So what we're going to do is break down each heading of the SOAP note, all right, so you can get a better idea of how to write a better SOAP note. So the first one is subjective, right? It's the first heading of a SOAP note. And documentation under this heading comes from subjective experiences. That could be personal views or feelings of a patient or someone close to them. And in the inpatient setting, just out of curiosity, if you feel comfortable, how many of you are inpatient versus outpatient? You can type IP or OP in the program. So I've got some inpatient in here. So a lot of outpatient. Great. All right, fantastic. So for inpatient, interim information is included, but for outpatient, this is going to be, again, sitting down and talking about the person's experiences, what their views are. So the first thing that you need to do is state who the note is talking about. And the reason why is if you find yourself in a liability situation and the patient states, I didn't state that, or accuses you of false documentation, it helps your case if you have the patient name and the gender by using pronouns in your note. Now, I tell you this because for several years, I'm the largest law firm on Southeast that represents hospitals. I was not a legal nurse consultant, but I was their nurse expert for mental health. So I know a little bit about liability and a little bit about lawsuits. Good documentation versus poor documentation. Then there's that old saying that if you didn't document it, it didn't happen, right? And unfortunately, that's true. You can also over-document. We're going to talk about that a little bit as well. But again, if somebody says, that I didn't say that in the note, it helps if you use the patient's name in your statements and use their gender, like he stated, she stated. Now, if you have ICANotes, you're lucky because the program does this automatically for you. But if you don't have ICANotes, you need to get it, or you need to make sure to include the name of the patient in the body of the note. Make sure that name is within the body of the note. All right. Now, to cover these conditions that the patient is stating systematically and to ensure that you don't miss anything important, a good rule of thumb is to follow this old charts acronym. And you can see that listed in the slide. However, in mental health, most of the subjective information is charted in the chief complaint. So the chief complaint of the presenting problem is reported by the patient. That can be, again, a symptom, a condition, a previous diagnosis, another short statement that describes why the patient is presenting today. The chief complaint, I want you to think of it as similar to the title of a paper because it allows the reader to get a sense of what the rest of the document's going to entail. So there's examples like, I feel like I want to hurt myself. I feel anxious. I feel like giving up. There could be other things like, I have shortness of breath. My appetite's been decreased. I have been cutting myself. Things like that. These type of statements that can be documented in the subjective section. Now, if you're doing for progress notes and follow-ups, that's great. But if you're doing a complete assessment and you have that history of the present illness that you're working on, the HPI, the history of present illness, begins with a simple one-line opening statement, and you're to include the patient's age, sex, and reason for the visit. Now, on ICANotes, our program makes the history of present illness and chief complaint pretty simple because you gather the patient information, and it puts it right in the first statement of the complete assessment. But the main thing, it's important for clinicians to focus on the quality and clarity of the patient's notes rather than include excessive detail. You need to be clear, concise, and have very professional statements. Because, again, as I told you what my background is, we live in a culture of very high liability. People are practicing defensive medicine. How many of you have heard of that term, defensive medicine? Yes, unfortunately, right? So, absolutely. It's unfortunately one of the things that people are having to practice now. So right now, and if you don't believe me, you can do this yourself. If you type in Google, how to sue my therapist, 12,700,000 results will pop up. If you type in, how can I sue my psychiatrist, 13,600,000 results will appear. That's why documentation is so important. You know that. You know documentation is important, or you wouldn't be in this webinar right now, right? So let's move on to the objective portion of the SOAP note. Okay, so we've talked about subjective. Let's do objective and really what that means. So for objective, and charting SOAP notes, sometimes people get things backwards. A common mistake is distinguishing between symptoms and signs. Symptoms are what the patient's subjective description are, and they should be documented under that subjective heading, symptoms, while a sign is an objective finding related to the associated symptom reported by the patient. So an example of this is the patient stating, I feel really depressed. That's a symptom. That should be documented under the subjective heading. Versus the patient has a PHQ-9 score of 25 that indicates that depression, and they're exhibiting body posture and attitude along with facial expressions and general demeanor that convey or reveal depression. All right, that's objective. Now, medical assessments versus mental health assessments are very different. And I'll be really honest with you, I truly believe that treating patients with mental health issues requires more disciplined thinking that is clear, rational, and open-minded. And let me explain, because that's a bold statement I want to explain. When you work in a strictly medical profession, such as cardiac care, in the first 5 years of my nursing career, I was in the ED on the cardiac care unit. You have a variety of labs and measures such as blood pressure and definitive lab results that are objective. If your white blood cell count is elevated, the numbers don't lie. If blood pressure or blood sugar is elevated, there are protocols that you follow because it's black and white. Mental health is gray. What worked for the last patient may not help this patient. But in the medical field, if I have a patient whose blood sugar is elevated and I give them insulin, it will bring it down 100% of the time. So if you're in this webinar and you care for individuals with mental health issues, you know exactly what I mean. And I'd like to see people kind of confirm that by typing yes in the chat. How many people feel that way, that it's a little bit, it's much more difficult when you're working in mental health to be able to do that? Yeah, I'm getting some yes, yes, yes. Thank you. Absolutely, yes. So again, mental health professionals have this really difficult job because they have to assess, they have to analyze, and they have to evaluate the patient without the use of lab and numbers. Because I can't draw your blood and tell how depressed or anxious you are. And every other medical profession has the ability to observe via radiology, via blood tests, examining pressures, even doing exploratory surgery to figure out and physically see those issues. But for mental health professionals, you have to closely observe the patient for anything that it can either confirm or contradict information provided in that subjective section of the notes, right? So patient is subjective, you are objecting. You're looking to confirm what they say, or sometimes, you know, the patient, they say a statement and it's not necessarily, their affect is completely different from what they're saying to you, and you have to figure out what's going on. So it's difficult. It's very difficult. Well, now I'm going to move on to the assessment part, and we're going to talk a little bit about that as far as an assessment. Again, assessment is this synthesis of subjective and objective. So this is the assessment of the patient status through you analyzing the problem, possible interaction of problems, and changes of status in the problem. Now, this can be as simple as a single diagnosis or multiple diagnoses. It could cover a range of problems that they're experiencing. But since we have a variety of professions in this webinar, I saw from the poll, thank you very much for filling that out. I'm going to review several different note types per discipline, and I'm going to show you different examples. Okay. Now, depending on what information has been derived from any lab test or rating scale or definitive diagnosis, that may not yet be viable to you. So we're going to provide your analysis of the patient based on the most up-to-date information you have in the assessment. So you either have a diagnosis that's already established and you can pull that right into your assessment, or you may not have yet determined their diagnosis. They may be very new to you, sitting right in front of you, and it's your job to figure out exactly what's going on. I see that most of the people in here have the ability to diagnose. So now, in ICANotes, as far as assessments, our program, you can free text additional information, but you can also let the program populate the diagnosis, and that will meet basic SOAP note criteria. And I'm going to show you how to do that. I like to show instead of tell. Okay. Now, the next thing that we're going to talk about is the plan. All right. Now, in mental health, treatment plans are essential to care. If you're working with CMS and you have Medicare and Medicaid patients, or your facility is involved with CARF or the Joint Commission, you don't have a choice. You have to do a treatment plan, right? So, but this plan, it's the final element of your SOAP note, and that encompasses the course of treatment that's planned to address specific deficits described in the assessment. Now, the plan should set a clear roadmap. Really clear roadmap for the patient or another clinician to be able to come in and continue treatment if needed. And the plan should always be related to the assessment and also the following visit. So what you're doing today, what you did last time, so that progress with that plan can be appropriately assessed. That's one thing with our treatment plan. Not only do you want to say we have a treatment plan, you want to talk about how the patient is doing with that treatment plan. Are they doing good? Are they making progress? Are they not making progress? Because so many times, I know you guys have created treatment plans and you go in and you have the best short-term goals for the patient and they're just not going to do it. And so you have to document that again as why in the SOAP note. So now, following the SOAP style, that is going to ensure that you consistently document the patient's current condition and progress in treatment. Now, good notes provide documentation that the clinician is following, one, acceptable standards of care, that you are utilizing appropriate interventions, and not only are you utilizing those appropriate interventions, you were describing the results of these interventions and documenting the dispositions of this case. Okay. Now, we have in our program the ability, and I can teach you how to create a 2-minute SOAP note in the program. It doesn't matter your discipline or what type of patient you see. If it's an SPMI patient, the severe and persistently mentally ill, down to a personality disorder, any SOAP note along with a burp note and other notes can be created in 2 minutes flat. And again, I'm one of those people, I like to show instead of tell. I could sit here all day and tell you something, but I like to show. And before we jump into the program, I have just, for the conclusion of my slideshow, I have a quote by the great Dr. Larry Wheat that I think is a really nice quote. The religion of medicine is not the feats of intellect. The religion of medicine is helping to solve problems of patients and the compassion involved in the very act of care. I love that statement. I love that quote. It really resonates with me, and I hope that that it resonates with you as well. All right. So I've got some great comments here. If you have questions, please don't hesitate to put those into the chat. I will be happy to answer any questions you have. I see Laura says, are there slides up? I only see the face page. Now that might be, let's see. If you're using, try to log in using Chrome or Firefox or Foxfire, because Internet Explorer does not play well with the big marker. conference hosting webinar. Oh, you're on Chrome. I'm not sure. Yes, absolutely. I can send a copy of my PowerPoint presentation. I will absolutely be happy to do that. I'll be happy to send handouts to you. Absolutely. So if you want a handout, just type handout in the chat and I will make sure and get those to you. All right, fantastic. Fantastic. So right now I'm going to be going over how to, absolutely, absolutely, thank you. I'm going to be going over how to do a SOAP note. Now I'm just really quickly, I'm going to look at our polls and see. So I have most of the folks in here are therapist counselors. So I'm going to focus on that note, but I'm also going to focus on provider. And then I have some community support folks in here, so I'll go over those notes. I have no nurses, that's okay. And then other, if you typed other in, let me know what your line of work is, and I will make sure that I get a note that works for you. All right, so right now, I am going to just go in, I'm going to delete this note. So right now, we're in ICANotes, and I'm going to show you how to create notes in here, right? And so we'll go over that. Out of curiosity, does anybody know who this is? Who our patient of the day that we'll be focusing on is? That's extra bonus points if you get that right. Piper, yes. All right, absolutely. All right, I got a lot of, okay, I have a lot of Orange is the New Black fans in here. Fantastic. All right. I judge people by what they watch on television, and you guys are excellent. So thank you. All right. So Piper Chapman has a lot of things going on. We have borderline personality disorder. She has a lot of different diagnoses: hoarding disorder, generalized anxiety disorder, binge eating, major depression. We also, in the program, we have every ICD-10 code available to you, and DSM-5 converts to ICD-10. So as you can see, that she was sucked into a jet engine. That's a subsequent encounter. That is actually a true ICD-10 code, and a balloon crash subsequent encounter. Like that would happen twice. So, but there's a diagnosis for the patient. And I'm going to actually work down the list. So I'm going to start in a prescriber note, show you exactly how that's done. A SOAP note is done in the prescriber note, okay? Kara, all right, absolutely. I will cover that. Thank you. Thank you. All right. So when I go into the prescriber note, and I'm going to go to the simplified view so we can look at that. The simplified layout, I could start with clinical complexity, but over here I have some custom buttons that I could use, and I could simply go in and talk about the subjective part of the assessment. Now, custom buttons are buttons you create in ICANotes. We have our own shrubs, but then you have the ability to create your own documentation as well. So I created a button that says, for my SOAP note, subjective, objective, assessment, and plan. My subjective, and I've already got the patient's name in there, Miss Chapman states, and I could just type, she says, I am very depressed and I eat all the time. How some people say, I eat my feelings. So subjective, this is what she states to you, right? Now, as far as objective, I could go in and I could actually do an MSE on her. So I could physically go in and start an MSE with this patient and go in and start talking about an MSE and everything we've done in an MSE. If it's normal, we have a nice normal here, but unfortunately, Piper probably isn't quite normal in her exam. But you did see, I'm able to click the normal button, gives me a beautiful, nice, normal mental status exam for this patient. But again, Piper's not normal if you watch the show. So I can go in and talk about the subjective things that I see. Maybe she is very sad and she's come in and she's disheveled and she's just very unhappy. Okay. I can talk about her speech and language. I could say that those are normal. I could say she has a depressed mood. So I could literally come in here and say, you know, it's her body posture and attitude, facial expressions, and general demeanor that I'm seeing right now. I can go back to the MSE and I could talk about her affect. I could say that it's flat. I'm able to do that. And I'm able to go in and say maybe I could talk about her suicidality, if she's homicidal, what her cognition is, if it's normal, insight and judgment. I can talk about anxiety. I can say, yeah, she has some anxiety. And what I see is that she's distracted, she's fidgety, she has poor eye contact, and she's a little bit oppositional with me. All right. So I could go in there and I really right away, I've got this nice subjective kind of information, or excuse me, objective information on the patient. All right. So I could go back. Now I could also go into, and this, I would put this over here as my objective. Here we go. Objective right there, and lay that out in the MSE. Now, and I could just take all this information and pop it right in. Okay. So I'm able to do that without any problem. So now the other part that I can go down here and put in, we've got a little click happy, type happy there. So I can go in here now and I can put my assessment. Now I've got the program already planned. When I click assessment, it comes in here and it sticks in all those diagnoses that you saw earlier. The borderline personality, the sucked into a jet engine, all of those things. It puts that right in there. Now, maybe we're not talking about her trauma for her balloon crash and sucked into a jet engine, so I could technically remove those, right, if I needed to. I could just take those and pull those out and just focus on some of the things that we're talking about today. Perhaps we're just dealing right now with the major depression, binge eating, general anxiety, and hoarding disorder. Okay, maybe those are some of the things that we're talking about now. And then I could go in and talk about the plan. All right, so I'm able to go in and talk about her plan. And so I could just click plan. Now, this is where it gets really interesting in ICANotes. We have the ability to link treatment plans in. So once you create a plan within ICANotes, I can go into depression. I can select depressed mood. I have a multidisciplinary plan. So I can go ahead and put that in. And so there's all my short-term goals. And then under that are my interventions for each short-term goal. Now, ICANotes is very interdisciplinary. So you can see up at the top, I have prescriber, I have therapist counselor, I have my recreational therapy, and then I have my nursing. So I can go in. Right now, we're dealing with her plan as far as a prescriber. So I could just select the prescriber portion. I could link that intervention in. It will say my long-term goal. It will tell me my target date, my short-term goal, and my intervention. Now, again, we said if you're talking about your plan, you need to talk about the progress in meeting the goals and what you're doing with that plan. That's what you need to do with every treatment plan every time you're addressing it. So I'm going to say that right now she's doing good with that treatment plan. And because she's doing good, we're going to continue the current plan because we've seen some progress. So I'm able to document that really easily on the patient. I can head back in. And now I've got this really great note. I can go in and say this is a progress note. Again, this will be as a prescriber. Prescribers get drug allergy pop-ups and things like that that you'll be seeing. This is just part of the program. We like to give you clinical decision support rules and also provide you with patient education materials for your patient. And so there I have all in here is I have my nice SOAP note. So subjective, objectives, my assessment, and my plan. All right. And then on the provider's note, it is going to list all the medications that the patient is taking, whether they're verbal orders. And as you can see, she's got some Red Bull and some Diet Cokes in there and fake meds. So, but I've got a whole complete note just by kind of clicking my buttons. All right. So that is a prescriber note. Well, thank you, Amy. Thank you so much. Now I want to go into a therapist note because the majority of you that are in here are counselor therapists. So let's go through. Now I showed you how I wrote out subjective, objective assessment and plan. You can do a shorter version of that. Again, I told you we could do a 2-minute version. I'm told we can completely do that. And I'm going to do a little bit different this time. All right. So we're going to go in. I'm going to say non-RX, which just means non-prescribing note. I'm going to go in and I have my SOAP note buttons here. Right? So I can go in and I could say subjective. Let's say Piper's having a hard day. So I could say Piper states, I'm not happy. I have been buying things on Amazon. This is a dangerous path. We can all become hoarders with Amazon. So I've been buying things on Amazon. I have been eating my feelings. Excuse me. All right. Now, objective information is I could go down to the MSC. You saw the MSC already. So I could go in and put a couple things in the MSC. I could say, you know what, her speech and language is actually not good. She's kind of like mumbled and slurred. I could go in and she's soft, okay? So I could go in and talk about that. I could say that, again, she's depressed in her affect and it's her thought content and she's crying right in front of me. And so, again, it's that slow speech and thought. That I could go down. I could talk about, maybe she said she's not suicidal, so she's not suicidal at all. But she still has anxiety. Now she's fidgety, restless, and distracted, and she has the poor eye contact. And she's being intrusive because she's going through my papers at the desk that I have her sitting at. So I could put all of that in there. I could also go into this area and I could talk about a little bit as far as my subjective. I could go in, and I actually forgot to put this in, which is fine. So my subjective, I could go objective, and I just have my O. I could put it in there, copy and paste it. You're able to do anything in the program like this. Some people don't like subjective and objective. They just use the S and the O. Okay, an A and P, so I'm able to do that. As far as my assessment, let's say for my assessment, I need to go in, and I gave her a PHQ-9 to fill out before she came in. So I'm going to go into my rating scales, and sure enough, I have a PHQ-A if you're dealing with adolescents, but I have a PHQ-9, and she's pretty severe. She was a 26. So severe depression there. And then I also did a suicide assessment on her. And she says right now that she's not suicidal at this time. So that's really good. But that's part of my assessment. I could also, with my assessment, go in and talk a little bit about behaviors. If I wanted to do that, I could go into the behavior shrub and talk about maybe her self-care is really reduced. And the great thing in ICANotes is you don't have to go in any particular order. So I could come down here and say her functioning at work is impaired and her socializing with others is reduced. And unfortunately, her substance use is more than advised. So, and her dietary information is that her diet, she's increased on her food and intake, and she has had some weight gain. Okay, so I could go in and kind of talk about those things under my assessment. I did a PHQ-9, I checked for suicidality, and her behavior, I talked about her behavior a little bit. So I'm able to go in and do that. And then again, I can go in and link to the treatment plan. So I can go in and I can link to my treatment plan. There's depression, depressed mood, and she's not doing as well today, right? She was doing fine for the provider, but when they come to the counselor therapist, that's when it all comes out, right? So I got a question. Are the PHQ-9, et cetera, in the program? Also, yes, we have, as you saw that little list that I pulled down, we have tons of assessment in the program. I can show you, we even have custom forms and assessments. But right now, I'm going to say that we are trying to help her recognize and report her depressive symptoms. So that was a good question. And I'm going to link in that intervention. And right now, she's not doing so good. Okay, so there has been no apparent progress in kind of meeting these goals, and we're going to need to continue that current plan. More time is needed because she's not doing so great there. All right, I'm able to do all kind of formatting changes that I want in here with an ICANotes. You're able to format, it gives you the information. And I can go back and then I can save as a progress note. Now I am going through and explaining these progress notes to you each time. So it's taking me a little bit longer than the 2 minutes, but you know, if you were proficient with this and within the program, it would be 2 minutes or less with these progress notes. So I've got my subjective feelings there, my objective with my mental status exam, my PHQ-9, my suicidality, my behavior. Her diagnosis is now in there for that. So I've got the diagnosis in there, and then I also, for my assessment, and then I also have my treatment plan. So there's my link to treatment plan, depressed mood, long-term goal, short-term goal. And so this is a really nice note for not having typed all of this. How long do you guys think that normally a note like this would take to type out? 15 minutes at least. So 25, yes. Yeah, I agree. I am with you. So, Amy, you're a fast typer. I'm with Jasmine and Renee. It's about 30 minutes for me. So, Jackie, you're fast too. You're very fast. So, it's easy to get your SOAP notes done in the program. It really is. You can use multiple different features to get your SOAP notes done. You could do it from any area. Someone asked about custom forms and assessments. Not only do you have rating scales that we can really quickly pull out, but we have a plethora of assessments within the program, whether you're dealing with adult assessments, so all the very popular assessments in here, the CAGE, the CWA, the GAD, the Hamilton, the Locus. As I'm just kind of scrolling down, you can kind of see everything that we have in here. The Mania, the Zung. We have gambling assessments in here, and then these are just adults. So all these are just adults, and then we also have our child assessments over here. One of my favorite things, and this might sound silly and benign, but if I could just show you really quickly, I love, and again, to some people this is really silly, but when I go to create a custom form, when I do like the PHQ-9, it will automatically total that up at the bottom so I don't have to count. I don't know why. I love that feature. It's probably one of my favorites, but most assessments do total together. So I can compile this and put this in the patient's chart. All righty. All right. So we've gone through prescriber, we've gone through therapist. I have psych assistant in here. I have case manager, which would be like community support. Psych assistant can be used for recreational therapy as well. So I can go in for recreational therapy and put that in. But let me just show you really quickly. For community support and case management, I can come in and I can just come in here and type like my S's in here. So I could go subjective, and then we could talk about, patient. We don't really like to use the word patient or client anymore. Again, that one thing in the program throughout all the notes, if you were following, it used Piper's name. It says Miss Chapman, and it said she is not suicidal, right? She reports. Those things are all in there. So again, you're using identifying factors, because I will tell you in my background in history, a lot of times people would say they were not talking about me. That note was not written about me from the healthcare provider. That was not me. And if you're a solo provider, it's different if you're in a hospital setting, but if you're a solo provider, a lot of times if you didn't use the patient's name and you didn't use those pronouns in the note and you didn't use those identifiers and you just put a sticker on the note or wrote the patient's name in, people have been found liable for that. So, and you've dealt with patients that come in and they don't really remember what they're talking about or saying. They may be in a completely manic state, right? And so that's why it's very important, whether you use this program or not, that you use those patient identifiers, okay? All right, so, but this is the case management type, a community support type note where a lot of people are actually out in the field dealing with the patient. A lot of times recreational therapy is out there doing that as well. So subjective, I would say I can type out, subjective is always going to be typed, okay? Like Piper states. And as you guys see, my typing skills are awful, so I have to have this program in my life. I love it. So Piper states, I am doing much better. My shopping and binge eating has decreased. I feel good. All right, isn't that great? So you can come in and you can talk about, she might say though, I feel like I need to cut because I was sad last week. But I didn't. Okay. All right. So I could come right in. I could talk about presenting problem is maybe that she is having some depression again there. So, but she's doing better. Okay. I could talk about social support changes that have occurred. So, and again, subjective, I could come back and say objective would be social support changes, and maybe there have been some changes that have occurred. So let's say, her best friend or one of her good friends died recently. That is when I stopped watching the show, just for y'all that watch the show. Okay, so those are some objective, those are some social support changes. I could also, with my social support changes, I could go back into the MSE. I could talk about her appearance. I could say that, you know, she's actually pretty calm today and she's talking to me pretty well. And she's still a little tense. I wouldn't say anxious, but she's tense. I could go in and talk about her behavior is that she is a little bit fidgety and restless and has a little bit of a depressed mood. So those are objectively what I see. So I could go into her assessment. I could pull in, again, for her assessment. You can just use the diagnosis, or you are able to do that. So just keep that in mind. I am able to do that for my assessment. I could just pull in her diagnosis. And then for her plan, I could, again, link in that treatment plan. It is the link to treatment plan is in every note that we have, even group therapy notes. So I could go ahead and link that in with depression, depressed mood, and I could come in here and say that, I'm just going to pull out here and say that this is the, right here, my short-term goal. We want her to walk at least 15 minutes a day. I'm going to link that intervention in. I'm going to say that she's doing excellent on that and that we are going to continue the current treatment plan. And the clinician there for recreational therapist is Sandy Crawley. So I can put that in there. Again, I can take out and format anything I want. You can even copy and paste in the program. So say you had some information from somewhere else, you could copy and paste it in here. Now we don't want you copy and pasting each note over, because right now Medicaid is on a tirade about cloning notes with the copying and pasting. People are having to reimburse large amounts of money for this because they say that if you clone the note, if you copy and paste the note, it affects the integrity of the note, right? So you've got to be really, really careful about that, okay? So again, I can do some formatting changes here to link up, but I've got a nice note here. And in reality, if I wasn't talking to you and explaining that to you, it would have taken me 1 minute to do that note. All right. So any questions? You guys are asking good questions, so thank you so much. Thank you, Sandy. Thank you, thank you. Any questions about the SOAP note? Laura said your SOAP is, your SOA is all shorter than mine, and your plan is much more intense. Right? Yes. Yes. Well, the one thing is you don't, again, this is me interjecting my background in there, not related to ICANotes and not related to the SOAP note, but just knowing the liability kind of sector here. You don't ever want to be, you want to use clear, concise, professional statements. You don't want to say too much, okay? You always want to document it. Documenting too little is bad, but documenting too much is just as bad, because that gives an attorney some ability to read into your note. And I have been on the other side of that. And I like attorneys. I mean, I think there's some really good attorneys out there. One of my best friends is an attorney, but they are brutal and savage when it comes in to those depositions. So just be aware of that. You know, it's a tough gig that I had, and so I only did it for 3 years, because it was very stressful for me, and I was not the one on trial. So I was just trying to help people. And so I don't want you to ever have to put yourself in that place of that clinician. I hope that never, ever happens to you, but documentation is so important. It's so important. So, and that's why I love ICANotes, and that's kind of what brought me to ICANotes. So, example of too much and another one that's revised. Yeah, I would be happy to write an example of too much. Sure, absolutely. I will actually put in, without saying too much, I will put in some of the things that got people in trouble. How about that? Some of those things. Stephanie said, loving this program, so affordable. Well, thank you so much. So right now, Sandy has kind of posted up, I'm not sure if you're able to see that on the screen, but there is a free trial of ICANotes. It is, let me know if you can see that, but there is a 14-day free trial, no credit card required, I'm not going to try to hem you up by getting your money, and then a lot of programs do that. Try to get your money, start charging you, and then you get busy and you forget. So this is a 14-day free trial, no credit card required, and it's a free trial. Are you able to see that on my current screen? I can see it on the screen, but are you able to see that on my current screen? Yes, you are. Okay, fantastic. All right, perfect. All right, so yeah, let's go into a note. And I will use some examples from the past. Deb is saying, is this free trial available at a later date? Sandy? For you, Deb, yes. How about that? All right. So I'm going to go into the chart face. And we are going to go right into, let me make this a little bit bigger so you can see it. This is our chart face within the program. Again, we have lots of different note types in here. We have group therapies. We have dietitian, again, and not only do we have groups like couple and marital therapy, but then if you have large groups of people, it's very easy to document on those. But yeah, definitely I can put in a note that saying too much. One of the other, before I do that, I just want to show you one other feature of the program that I love. How many of y'all are really big on patient education? If you type yes in the chat, I'll go into that. If not, we'll just move forward. Yes, Tammy's like, yes. Me. I love it. Okay, excellent. And yes, there was a question about primary care. We have review of systems in here. We have medical screenings. Yes. We absolutely do have that. We have a lot of primary care physicians that use this program. Behavioral health primary care, regular primary care, even OBGYN. So if I go into the logs section, we have logs on everything. Medication logs, we have problem diagnosis logs. One thing I'll show you really quickly that I love is I have rating scale logs, so I'm able to trend out all those rating scales that we did on the patient. I'm able to trend those over time to see how the patient is doing. So are they getting better or worse? What's going on? And we have that for a lot of different logs. But I have a problem diagnosis log. And everywhere you look, there's these little blue buttons within the program. So these are patient education materials. And so I could click on that, and it'll take me directly to Medline Plus. And anytime I come in here, to Medline Plus, I can print this information. Every time I hit print, it keeps a record of the information that I'm printing out and gives you percentages to your patient. Now, if you don't want to see that, you don't ever have to see it, but it's in here, and it always takes you to a reliable source. So it's not Google Doctor, it's Medline Plus, and it gives you accurate information for your patient. And these are really good for those really kind of hard diagnoses like schizoaffective, if you're diagnosing someone the first time with borderline personality disorder and they want more information, this is a really, really good source for that. Okay. Same thing if let's say you're going through medication logs, you see that every single medication has a little blue button that I can immediately pull up information, that patient education materials that I could print out for my patient that is legitimate, because so many times today there is non-legitimate or incorrect information on the internet. Right. So, all right. So any other questions? I am going to go in and type a note. Let's go into the progress note, non-RX. And I'm going to put a really bad note in. Now let's say we have other buttons in here. So I'll show you. Let me show you first what if you're not using a SOAP note, okay, there are all kinds of note types, but let's say that your patient comes in and you're not using a SOAP note. Maybe you're doing a regular type note face. I could go in and talk about the patient's, depression. Maybe let's say the patient, well, let's let you guys judge. Do you want the patient to be better or worse? You tell me. First one gets it. Better or worse? First one that types it in. Worse. Right. Amy, I think you were the only one that said better. I'm sorry. So Jasmine got it. All right, exactly. Everybody's like worse. Okay, so I'm going to say that depression is present and it continues, and the frequency and duration, it's way worse. It's episodic, it's daily, the mood lasts for hours. She is worse. And then I can drill down into symptoms, like she's having crying spells, and those are worse. And she's having fatigue, and that is much worse. And sadness is much worse. And I can say that she is having feelings of worthlessness, and that's worse. Sometimes you can just say the symptom is present. So I could say your irritability is about the same. And then I can talk about suicidality, and I can say that you always want your patient not to be suicidal, right? So I can say that she's not suicidal and her denial is convincing, thankfully, right? So, oh goodness. And so then Amy's cracking me up. Sorry. Then I can go into, I could talk about my patient's behavior again. I could say she's irregular with medication, self-care is reduced, again, more than advised, functioning at work is impaired, she's isolated with others, her anger is poorly controlled, impulses are poorly controlled, she has really horrible sleep problems, falling asleep, staying asleep. And I could go back, and then I could go into verbal content. So what did we do today? So we talked about her depression, and we talked about some self-defeating behavior, and some low self-esteem, and we talked about the feelings of shame and guilt and anger that she has. And then I could go into what did you do, right? She's having all these feelings, and so the therapy focus there is I've given her, and we have everything as far as therapy focus. If you don't like what's on the list, we take the top things that people deal with, but we also have pop-down lists that deal from everything from early childhood development to hospice, okay? And so I can come in here and say we're talking about, our therapy focus was coping skills, and then I gave her support and encouraged her to vent feelings. Okay, and then I can go back in there and I could say this is a progress note. You can, of course, build through the program. I can put length of session, but I can say this is a progress note. Now, again, this is not a SOAP note. This is just a regular note. And so I've got this regular note. I was, again, talking you through it the whole time, but you see very quickly I have this really beautiful note that's well laid out regarding this patient. Has her diagnosis on there, has what's going on, her behavior, content of therapy, therapeutic interventions, and her diagnosis. So is that pretty? I think it's pretty. What do y'all think? I love it. So that's one of my favorite parts of the program. It's like pretty fantastic. Yes, very, very pretty. So, but there was one question that I wanted to address. So, one of the things that I have seen, somebody said, can you give me an example of a bad note? Okay, things that you would never want to document. There are certain words that you cannot say, and you guys probably already know this, but people just get busy. There are certain things that you cannot say in the program. So, or not in the program, but just in general, you cannot call a patient a liar, right? Even though you think that they may be falsifying statements, you have to use terms that are very clear, again, concise and professional. So you have to worry about the way that you say things. So for instance, here, okay, you don't want to say that, as far as symptoms worsening, patient is complaining more. You do not want to use that term, like patient complains more about, because it sounds like then, even though they are maybe complaining more, that's not a statement that you want to use. Sadness has, patient states that they are more sad, but things like that. I've literally had somebody say, what does more sad mean? Define more sad. No, it's worsened, it's gotten better, it appears more extreme, but more sad. I've had more attorneys rip people up over grammar and punctuation and spelling, because they will then go in and start to demean and criticize the author of the notes and their professional abilities. So you have to be very, 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 very careful when you're writing a note. Okay, you may be tired, it may be the end of the day. A lot of people write their notes at the end of the day, and they've seen a lot of patients. Your schedule's full, you're tired. And so you've got to really think about what you're saying in your note. One of the statements that I just used that I think is important is Miss Chapman denies suicidal ideas. Well, a lot of times what we've heard is, well, how do you know that she really wasn't suicidal? I believe the denial's convincing to me. So that denial's convincing. Not only is she saying she's not suicidal, I've seen her before, we have rapport, denial's convincing. Simple statements like that can get you out of a lawsuit. So, exactly. Miss Williams says, yes, spelling and grammar on a legal document, so important. So important. So, Well, thank you guys so much for your time today. If you have any other questions, I'd be happy to answer them. I really appreciate your time. I went a little bit over. We're already at 12:56. I think I've cut into some of y'all's lunchtime, so I apologize. But thank you, and you've been a really, really interactive crowd, so it's been just a pleasure. All right, so thank you so much, and have a wonderful day. All right, thank you. Thank you. You guys have been wonderful. Thank you so much. Take care.